I'm Dr. Radhika PM, Associate Professor from Ramaya Medical College. Today we'll be learning about the clinical anatomy of nerves of lower limb. Disclaimer: all the images and videos used in this presentation are from the textbooks of anatomy and various internet sources. The images are used for teaching learning activities only. The video is done to help the undergraduates understand the clinical anatomy. I acknowledge the ownership of the images and give complete credit to them. Coming to the specific learning objective, the student should be able to describe the clinical anatomy of nerves of lower limb. Coming to the first clinical case, a 35-year-old male came with the history of sharp radiating pain from the lower back through the buttock and down to the back of the right leg. He also complains of numbness in the foot. So in this case, if you see, there is a sharp radiating pain which is radiating from the lower back down to the back of the right leg. He also has numbness in the foot. So what is the diagnosis and which is the nerve which is compressed? The condition is called as the sciatica. Sciatica means the pain radiates along the sciatic nerve from the lower back down through the buttocks to the legs. It is caused by the compression or because of the irritation of the sciatic nerve. Often it is resulting from the herniated disc or by the spinal stenosis. What are the symptoms of sciatica? So the symptoms include shooting pain, numbness, tingling and weakness, usually in one leg. So here you can see this is the herniated disc. Coming to the anatomy of sciatic nerve. Sciatic nerve arises from the lumbosacral plexus. The root value is, it has two components, the tibial component and the common peroneal component. The tibial nerve is from the ventral division of the ventral rami L4, L5, S1, S2 and S3, and common peroneal nerve, this arises from the dorsal division of the ventral rami L4, L5, S1 and S2. So these are the two components of the sciatic nerve. Coming to the branches, so it supplies the hamstring muscles. There are four hamstring muscles: semitendinosus, semimembranosus. Then you have the biceps femoris, that is the long head of the biceps femoris, and the ischial part of the adductor magnus. So these four muscles are supplied by the tibial component of the sciatic nerve, whereas the short head of the biceps is supplied by the common peroneal part of the sciatic nerve. The sciatic nerve gives articular branches to the hip joint and it divides into two terminal branches, that is the tibial nerve which runs in the midline, and here you can see the common peroneal nerve. So whenever the sciatic nerve is injured, so both the common peroneal nerve and the tibial component both will be affected. Coming to the second clinical case, a 35-year-old female complains of numbness of right leg suddenly at midnight and relieved by tapping the foot hard. So this usually we see when a person is sleeping and on a hard uh, bed, or if they are sleeping on the floor, sometimes they will have this numbness in the leg, and it is usually relieved by tapping the foot hard. So what is the condition? So what is the diagnosis and what is the anatomical basis of this condition? So this condition is called as sleeping foot, and it is because the sciatic nerve lies on the quadratus femoris. So this muscle is the quadratus femoris, and here you can see this is the adductor magnus. So it lies between the quadratus femoris and the adductor magnus, and between these two muscles the nerves lie on the hard femur. So it gets compressed by the hard femur. when you're sitting on the table or chair or on the bed for a long time. So usually we feel the numbness of the lower limb till the foot is hit back. Till then you will have the numbness and later it becomes okay. So this condition is called as the sleeping foot, and the main reason is the nerve gets compressed between the hard edge and the femur. So the relation of the sciatic nerve is important to know the anatomical basis of this condition. Sciatic nerve is also important when we give the intramuscular injection. So intramuscular injections are given at two places. One is in the deltoid and the second is in the for the gluteus maximus. So what we usually do is we draw two lines in such a way that the gluteal region is divided into four quadrants. So in the medial quadrant, if you all see, you can see the sciatic nerve. So to avoid damaging to the sciatic nerve, usually the intramuscular injection is given in the upper outer quadrant, that is the upper lateral quadrant of the gluteal region, because along the medial quadrant you can see the sciatic nerve. So if you give injection to the medial compartment, medial quadrant, you can injure the sciatic nerve. Now the next clinical importance of the sciatic nerve is the piriformis syndrome. So sciatic nerve comes out through the greater sciatic notch and it is present below the piriformis. So piriformis muscle can compress the sciatic nerve and this results in the radicular pain, numbness, muscular weakness, and there is a buttock tenderness. The pain can be exacerbated by the internal rotation of the lower limb at the hip joint. Now coming to the third clinical case, a 45-year-old male sustained a road traffic accident 2 months back, had a fractured neck of the fibula, and the limb was immobilized in the plaster cast. After the removal of cast, the patient complains difficulty in walking and tripping over his right foot for past 2 days. So here you can see there's an history of fractured neck of the fibula. So what is the on examination, the foot is held in the plantar flexed and inverted position, and he had an inability to dorsiflex and eversion of the foot. So the foot is in the plantar flexion and it is in the inverted position, and the person is not able to dorsiflex or evert the foot. So what is the diagnosis and which is the nerve which is compressed? So foot drop is a condition which is due to the damage to the common peroneal nerve. The common peroneal nerve winds round the neck of the fibula, and if there is an injury to this results in the paralysis of both dorsiflexors and everters. Because common peroneal nerve will give rise to two branches, that is the superficial and the deep peroneal nerve. Superficial peroneal nerve supplies the everters, whereas the deep peroneal nerve supplies the dorsiflexors. This results in the foot to hang in the plantar flex position and in a inverted position. The patient mainly exhibits the stepping gait in which he has difficulty in lifting the knee high to prevent the toes from dragging. This is the normal gait, and here you can see this is the steppage gait, which is a common gait in case of foot drop. In this condition, the person will not be able to lift the knee and there will be dragging of toes on the ground. This is called as the steppage gait, which is commonly seen in the foot drop. Now coming to the common peroneal nerve. The common peroneal nerve arises from the dorsal division of the ventral rami L4, L5, S1 and S2. It winds round the neck of the fibula. So here you can see the sciatic nerve which is dividing into, this is the tibial nerve and this is the common peroneal nerve. The common peroneal nerve, it terminates into superficial. So superficial runs in the peroneal compartment And the deep peroneal nerve, it pierces the intermuscular septa and it comes to the anterior compartment and it lies along with the anterior tibial artery. The common peroneal nerve branches, so muscular branches to the short head of the biceps femoris, cutaneous branch to the lateral cutaneous nerve of the calf. It also gives sural communicating branch which joins with the sural nerve. Sural nerve is a branch of tibial nerve. Sural communicating is a branch of the common peroneal nerve. It also gives articular branches to the knee joint through superior, inferior lateral genicular and also through the recurrent genicular branch. Coming to the terminal branch, there are two terminal branch, superficial and deep peroneal nerve. Coming to the superficial peroneal nerve, it's a terminal branch of the common peroneal nerve. It's a nerve of lateral compartment or also called as the peroneal compartment. Mainly it supplies the peroneus longus and peroneus brevis and it continues as the cutaneous nerve of the leg. Now this superficial peroneal nerve can be compared with the musculocutaneous nerve of the upper limb. So after supplying the muscle, it continues as the lateral cutaneous nerve of the leg. So superficial peroneal nerve, it supplies the lateral aspect of the leg and also the dorsum of the foot. So the whole of dorsum of the foot except for this web space is supplied by the superficial peroneal nerve. Coming to the deep peroneal nerve. Deep peroneal nerve is a terminal branch of the common peroneal nerve. After piercing the anterior intermuscular septa, it supplies the anterior compartment of the leg and this nerve accompanies the anterior tibial artery. Coming to the muscular branches, it supplies the muscles of the anterior compartment which includes tibialis anterior, extensor digitorum, extensor hallucis and peroneus tertius. It also supplies the extensor digitorum brevis. Coming to the cutaneous branch, so the web space between the great toe and the second toe, this area is supplied by the deep peroneal nerve. It also gives articular branches to the ankle, tarsal, tarso-metatarsal and metatarso-phalangeal joint. Now coming to the clinical case for a 37-year-old male presents with the difficulty in walking, especially while pushing off the foot. He has numbness and tingling over the sole of the foot. The patient sustained a deep lacerated wound in the popliteal fossa following a road traffic accident 3 weeks ago. So here if you see there is a numbness and tingling over the sole of the foot and he had a sustained injury in the popliteal fossa. So we have to know which is the nerve which is present in the popliteal fossa which supplies the sole. On examination, there is a wasting of muscles of calf and weakness of plantar flexion and there is a weakness of inversion of foot. There is an absent ankle reflex. So which nerve is compressed and what is the anatomical basis? So it is the tibial nerve which is affected, which is a nerve which is present in the popliteal fossa. It's a branch of sciatic nerve, mainly supplies the posterior compartment of leg. So there, in the case history, there was weakness of calf muscles and also atrophy of the calf muscles. And injury to the tibial nerve leads to dorsiflexed and everted foot. So if it is plantar flexed, then we have to think about the common peroneal nerve. But here it is the dorsiflex and everted foot. So this is the injury to the tibial nerve. Coming to the origin of the tibial nerve, it arises from the ventral division of the ventral rami L4, L5, S1, S2 and S3. It arises from the popliteal fossa, descends vertically, lies superficial to the popliteal vessels, It descends to the back of leg along with the posterior tibial vessels. It gives rise to muscular branches to the posterior compartment of the leg, and there is one cutaneous nerve which is called as the sural nerve. It gives articular branches to the knee and the ankle joint, and terminal branches it divides into medial and the lateral plantar branches. Now this tibial nerve can be compressed deep to the flexor retinaculum. So this is the flexor retinaculum. So when the tibial nerve gets compressed deep to the flexor retinaculum, this condition is called as the tarsal tunnel syndrome. Clinically, this presents with the burning and tingling sensation and pain in the sole of the foot, and it is usually relieved by dividing the flexor retinaculum. So if you cut the flexor retinaculum, it will relieve the pain. So here you can see this is the tibial nerve and this is the posterior tibial artery which is running beneath the flexor retinaculum, and the compression of this nerve results in a syndrome which is called as the tarsal tunnel syndrome. So here you can see the tibial nerve dividing into medial plantar nerve and the lateral plantar nerve. Now coming to the sural nerve. The sural nerve is a cutaneous nerve which runs along with the short saphenous vein, and it is the most preferred nerve for grafting because it is thick and it is long and it is purely sensory. The sural nerve joins with the sural communicating nerve, which is a branch of common peroneal nerve, to form the sural nerve, and it runs in the midline in the posterior compartment. This nerve is also prone to the painless neuroma. So to summarize, in video 1 and in the video 2, I have tried to explain the anatomical basis of injury to nerves of the lower limb with the clinical cases. So the most important nerves which we have dealt is femoral nerve, obturator nerve and the sciatic nerve and its branches. Thank you.